Good evening, sir. So you are completely audible. Shall we start?
Yes, Fatma, thank you so much.
So good evening, all the aspirants present here. The topic for today is endocrine disorder. And the speaker that we have here is Dr. Suvadeep Sen, sir. He is a consultant ICU at Apollo Hospital, Navi Mumbai. Yes, sir. So you can start sharing your PPT.
Is my PPT visible?
Yes, sir.
Just let me put it in the.
Aspirants, this is going to be an interactive session. Any doubt, any question, you can write it in the chat box. And also you can unmute yourself.
My slide is visible. Is that okay?
Yes, it's perfect.
Hi, good evening, everybody. Just let me see. Okay, so there are a good number of participants today. So I hope everybody of you are planning to prepare. You are preparing for your EDIC Part 1 examination. Can you hear me, everybody? So as Fatma has said, I would try to make it a little interactive kind of session. In EDIC Part 1 examinations, it is basically a multiple choice question, and I would like you to have a kind of interactive sessions over here. So we'll discuss few MCQs, and where I would like to know that how much you have prepared or not, and then how much you can you can just put your answers over here, and we can start. Okay, in today's session, we'll discuss the different topics of the endocrine disorders. We'll try to cover various kinds of thyroid disorders, adrenal disorders, diabetic emergencies, calcium and sodium disorders, and electrolyte disorders. We'll straight away start with few of the questions from few of the MCQ questions that are commonly asked in the EDIC Part 1 examinations. As you can see that whenever you see the questions over there in your whenever you're able to see the questions there, you just read the questions and then try to give answers from your side. And once we get the answers from most of you, then we'll try to discuss regarding the correct answers. And in the process, we'll discuss the various disorders and try to understand different questions and answers. So we'll straight away go to the first questions. So I think I have already taken one detailed I've already taken a kind of detailed uh, session on endocrine disorders, where I have discussed a lot of theoretical aspects on the endocrine disorders in ICU. Today, I will make it a kind of more question and answer based scenario, because I feel that the exams are quite near, and in the while we discuss the question and answers, so we'll try and understand the reasons for all this. The reasons for all these correct answers. So here, this is a kind of very basic questions on the thyroid disorders that you can see. So a 36 years old woman sees her general physician complaining of fatigue, 4 kg weight gain, dry hair and skin. On clinical examination, she has small diffuse goiter. Her TSH level is 16 and her thyroxine level is thyroxine FT3 and FT4 level has been given. So a total cholesterol level has also been given. So what is the most likely diagnosis? Again, this is a very basic questions on thyroid disorder. In EDIC kind of examinations, usually this is a kind of more medical questions. The reason for putting this question is to start the discussion on the thyroid disorders, so that in subsequent sessions we'll discuss a lot of endocrine emergencies related to the thyroid disorders. So as we see that the answers has already been started coming. So this patient has some thyroid disorders. So what thyroid disorders this patient has? I can see that there are answers in the chat box. Dr. Hiren, Dr. Dikane, and Dr. Dattatray. So all of you have given answers of C. Dr. Ranjit has answers B. So Here, it's a very basic question. So the answer is the answer over here is the C. So it's a kind of Hashimoto's thyroiditis. This patient has hypothyroidism. So this is just to understand that the whether we can identify this patient is hypothyroidism and the hyperthyroidism, and what is the most common cause of hypothyroidism in ICU. So that is what we need to know from this question. Now, to start, whenever we try and interpret a basic thyroid function test, we start by checking the stimulating hormone. This is how, with an algorithm manner, how we understand what exact kind of thyroid problem we have. So we'll just check the TSH first. If the TSH is elevated, then it is either it is a primary hypothyroidism or it is secondary hyperthyroidism. If the TSH is elevated, if the TSH is low, then it is either it's a primary hyperthyroidism or secondary hypothyroidism. To differentiate between the hyperthyroidism and hypothyroidism, what we check? We check the T4 level, and depending on the T4 level, we differentiate what primary basic mechanism, basic pathophysiology or basic thyroid disorders we have. The commonest cause of primary hypothyroidism is autoimmune thyroiditis in Western scenario. So whenever you give the EDIC kind of exams, it is the autoimmune thyroiditis which is the most important cause of primary hypothyroidism. In Indian setting, the most frequent cause of primary hypothyroidism is the iron deficiency. So in any kind of exams, the autoimmune thyroiditis is the commonest cause of, which is the most globally most prevalent cause of primary hypothyroidism. And the most common cause of primary hyperthyroidism the Graves' disease is the toxic multinodular goiter. Now, two three important things that we need to know whenever we discuss the thyroid disorders is that uh, the T3 concentrations are of no value when evaluating hypothyroidism, because the T3 value are often normal due to T4 to T3 conversion. So we always need to check the TSH followed by T4. So that is important. And whenever we are evaluating or guiding the treatment for somebody, we need to test the TSH value, because that tells us whether the treatment, irrespective of the patient is hypothyroid or hyperthyroid, whether the treatment are adequate enough. So TSH levels are more sensitive in guiding the treatment response. And to understand which blood test is the most sensitive to establish the excess thyroid or hormone activity is the free T3 level. So in any patients with a hyperthyroidism, to understand whether the patient is an active endocrine hormonal level they are in the body or not, we need to assess the FT3 level or free T3 level. So this everybody needs to know. For autoimmune thyroiditis, we check the anti-TP antibody, and for autoimmune atrophic thyroiditis, usually they're associated. They're usually not associated with any goiter. And if you need to know that the common causes of hypothyroidism and hyperthyroidism, the commonest cause of hyperthyroidism is the Graves' disease and the toxic multinodular goiter, and commonest cause of hypothyroidism is the Hashimoto's thyroiditis, Riddle's thyroiditis, iron deficiency, and the lithium. There are few sets like amiodarone, postpartum thyroiditis, subacute thyroiditis, or dequirement thyroiditis. They can present both in the hypothyroid phase or hyperthyroid phase, depending on which phase they are in. Coming to the question number 2, uh, again, again, one important thing is that at any point of time, if you have any doubt, you can just stop me and I'll ask questions at that point of time, rather than just putting the things in the chat box. You can just unmute yourself and ask the questions at that point of time. Second question is that a 63-year-old man admitted with severe pneumonia is hypotensive, hypothermic, bradycardic, hyponatremia, and hypoglycemic. TSH is 15. T4 is low, random cortisol is 170. What is the best initial therapy? So we have A, B, C, D, E. So please put your answers over here so that we can start the discussion over there. I'll just wait for some time so that you start putting your answers in the chat box. So here, this patient is having a severe pneumonia. First thing, what we need to identify what is the condition that we are dealing with, And once we identify the condition, then we will be able to give answers to the question. Here the patient is having a elevated TSH and low free T4 level. So what conditions, if you can tell me what conditions we are discussing over here? Anybody? What conditions we are dealing over here? You can just unmute yourself and answer. Okay, we have some questions we have already found the answers in the chat box. So all of you have given a kind of good answers over here. The answers, everybody has responded correctly over here. So everybody is very nice. So the answers over here is the B. So we need to give steroid first and then we initiate the vasopressin over here. So what is the condition we're dealing with? This is not again, this is not a adrenal crisis. This is a myxedema coma. Most of the cases of the myxedema coma, they are associated with some amount of adrenal deficiency kind of state. And that is why in any patient with the myxedema coma, we need to give, we need to give steroid first, and along with the steroid we need to, after giving steroid, we should give some thyroxine. So if you fail to identify the problem over here, and then it becomes difficult, because giving only IV levothyroxine or supplementation of the thyroid doesn't make any, it will not solve the problem. So it is important we give steroid, and after that we give thyroxine supplement in these patients. So discussing a little bit about the myxedema coma, it is one of the life-threatening situation. It commonly occurs in individual with undiagnosed or untreated hypothyroidism, when they are subjected to any kind of stress, like any infections or EMI or any acute illness. They're associated with a respiratory depression, bradycardia, hypotension, hyponatremia, altered sensorium, and hypothermia. And most of the patients, they require ventilator support for 24 to 48 hours, and measurement of the ABGs are mandatory to understand the acid-base status or the respiratory status for this kind of patients. What is the treatment of the myxedema coma? We need to give thyroxine, the loading dose. It's a kind of as initial therapy. The T4, in India, we usually get the T4, the thyroxine, or that we get, and we usually give the oral thyroxine when we do not, IV thyroxine is not available. In a lot of centers, IV T3 level, the T3 is also available. Leothyroxine is also available, and leothyroxine can be given. And before, as stated, steroid should also be given as the initial therapy before giving thyroxine. So we need to give hydrocortisone as 200 to 400 milligram IVs. And along with that, we need to treat the precipitating cause. We need to have a supportive therapy in terms of oxygen, non-invasive or invasive mechanical ventilation, passive warming of the patients, and management of the hypoglycemia and the hyponatremia, whatever the patient is present with. And patients often need vasopressor support for management of the hypotension. Coming to the question number 3, a 62-year-old ventilated patient with ARDS has TSH of 0.3 with FT3 of 11, which is low normal, and FT3 of 1.4, which is also low. Which test best helps distinguish the sick euthyroid syndrome and the true hypothyroidism? Again, sick euthyroid syndrome is one of the very favorite topic of all intensive care specialists, and especially all intensive care related MCQs and intensive care ICU related exams, like whatever you give ITCM exam or EDIC exams. Sick euthyroid syndrome is very favorite topic for all the examiners. So now coming to the questions. So how do we distinguish the sick euthyroid syndrome from the true hypothyroidism? So then there are A, B, C, D options. So can you just please post your answers over here? I understand that who is given answers for what. Okay, and answer has started coming. A. Good. I feel that everybody is reading very well. Everybody is studying very well. Again, these are all the questions which, if you know, then you'll be able to give a right answer. If you do not know, then it will be very difficult to give the answers. This kind of questions. So as I get to see, the kind of people have already started giving good right answers over here. So A, B. Okay, okay. So again, so a few of you know about this condition, few of you probably do not know about this condition. So that is why you are getting the different response. So answers over here is the RT3, or answer A is the correct answer. So how do we differentiate between the sick euthyroid and the hypothyroidism? We need to do the reverse T3 or RT3. So depending on the now talking a brief about the sick euthyroid syndrome. What is sick euthyroid syndrome? Sick euthyroid syndrome is happens in any patients who comes in the ICU with any acute severe illness that causes abnormalities of the thyroid hormone level in absence of any underlying thyroid disease. The patient doesn't have any comorbidity, any thyroid disease, but because of this acute illness, there is change in the hormonal level inside the body. So that is the state called sick euthyroid syndrome. Why it is important to diagnose? It is important to diagnose because most of the time, although we get to see a lot of thyroid biochemical abnormality, we don't need to treat that biochemical abnormality. That is why it is important to identify this entity, and that is why it is the dictum not to do any kind of thyroid testing for somebody who doesn't have any thyroid and doesn't have any pre-existing thyroid disorder, not to identify and diagnose a thyroid disease during the acute illness. So that is the dictum. So what happens in any severe illness? There is a release of inflammatory mediators that causes downregulation of type 1 dehydrogenase and upregulation of type 3 dehydrogenase, and which causes impaired peripheral conversion of T4 to T3 and increased synthesis of reverse T3. So that is the basic biochemical, basic pathophysiological mechanism that happens over here. So how do we identify biochemically the conditions? The classic pattern is that patient usually patients usually have low TSH with low T3 and low normal T4, and usually patients might be having a normal TSH also, and they can come with again kind of various permutation combination of the biochemical parameters of T3, T4, and the TSH. Most commonly, patients do have a low normal TSH and the low T3. That is the most common pattern that the patients have in the thyroid function testing. And classically, what happens? The RT3, because the upregulation of the type 3 dehydrogenase, so there is a conversion from T4 to the reverse T3. The T4 doesn't get converted to the T3. T4 gets converted to the reverse T3. So that is the biochemical abnormality, and increased RT3 is the most hallmark biochemical abnormality to differentiate between the true hypothyroidism and sick euthyroid syndrome. What is the management? Management is to treat the underlying illness, not the thyroid biochemical abnormality. Giving thyroid hormone in, it's called non-thyroid illness, may increase the catabolic state and the cardiac stress, which worsens the issue outcome. Like if we start treating this patient with thyroxine, then it increases the catabolic demand of the patient or metabolic demand of the patient, and it puts the patient into another metabolic stress or catabolic stress. So that becomes a problem. So patients might develop myocardial infarction, or this kind of things can happen. So, and how do we identify what is the most important poor prognostic marker? Is the progression to the low T4. If the T4 level becomes low, signifies the a very poor prognostic marker in any patients with a sick euthyroid syndrome, and that is a poor prognostic marker of the overall patient's clinical outcome as well. So this is the table with which we can differentiate between the sick euthyroid syndrome and true hypothyroidism. So there are laboratory parameters, the pathophysiologically they are different, and the management is obviously different. So we need to identify what is the particular cause of the what is the biochemical mechanism of the sick euthyroid. Coming to the question number 4, a 42-year-old woman with a Graves' disease is admitted to the ICU with fever atrial fibrillation with fast ventricular rate. I think it is a fast ventricular rate, delirium and the diarrhea. Her lab parameter shows elevated free T4, TCG suppressed. What is the correct first line sequence in the therapy? So again, the options are there: A, B, C, D, E. Again, treatment of the Graves disease is very popular questions in all intensive care related exams, and especially the EDIC exams. The Graves disease is a very common topic to ask. So, so I hope all of you know that how to manage the Graves disease. Graves disease again it's very if you do not if you can't identify Graves disease, then it becomes a problem, because this kind of patients, if remains undiagnosed, then these patients are continuously remains in tachycardia, in catabolic stress, and we need to identify that part. Now coming to the management of the Graves disease. So again, as I can see that all few of you have given answers to it. I don't know which. So I hope most of you have given response B as a correct answer. So Dr. Abhishek has given C. So answer over here is the why again the correct answer is C. Now why it is important to know, because in the Graves disease the most important is the first thing is we need to control the adrenergic symptoms. That is the most important part of the management of the Graves disease. That is the first thing. So we need to give the beta blocker first. So that is the first thing. These questions again are very common in the EDIC kind of exams, because in ICU whenever somebody comes, this propylthiouracil or thioiodines, they always require some time to act, because if we know the mechanism of the propylthiouracil, they mainly block the peripheral conversion from the T4 to the T3, and they will get absorbed and then start acting on the thyroid hormone, and they will diminish the synthesis of the thyroxine hormone. Before that, we need to have a symptomatic control of the patient. So beta blocker is the first line of the management in patients with the Graves disease. So the sequence, here the sequence matters. So as we have given, the sequence matters. The first thing, we need to give beta blocker to control the adrenergic drive. That is number one. Second, we need to give this thioiodine, this propylthiouracils, to block the T4 to the T3 conversions. And after that, we need to give iodine to release the to decrease the release. And it is again important to give iodine after administration of the propylthiouracil. That is one more important question. Sometimes that questions might come in a different way. The iodine should be given only after administration of the propylthiouracil, and at the same point of time we need to give steroid to prevent peripheral conversion from the T4 to T3 and give some amount of adrenal coverage. So this sequence is important to know in management of the patients with the Graves disease. We need to give beta blocker first, and then we need to give propylthiouracil, and then iodine, and then steroid. So coming to the okay, then another question on the same topic. A patient with the thyroid storm has mistakenly given IV iodine before anti-thyroid drug. What is the most likely consequence? So what will happen if you give IV iodine, or if you give iodine before administration of the anti-thyroid drug? Again, this is again one of the very common questions. A, B, C, D, E. So if you can just start giving your answers. So rapid improvement of the thyrotoxicosis, I think that is everybody will understand. No, that will not happen. Induction of the Wolff-Chaikoff effect, exacerbation of the thyroid hormone release, precipitation of the myxedema coma. No, I don't think that is the right answer. Acute adrenal insufficiency. No, that's not. What is the correct answer? So what happened? So should we give IV iodine before antiviral drug, or we give just 1 minute, hold on. Sorry, just have one. Somebody raised a raised hand.
Yes, it's me.
Hi. Yes, doctor, tell
Hi,
me.
can I just ask a question? You know the previous question,
Okay, yes, tell
before
me.
this one, I actually was thinking that I know it says on the stem that is grave disease, but looking at the parameters that they gave
Yes.
us, I
Okay.
was actually thinking this may even be a storm, although we were not given the actual values of the tachycardia, but the patient had an atrial fibrillation that will give him a 10 and a high temperature 5, a diarrhea at 10. So I was thinking he's more approaching that thyroid storm. And wouldn't that change the sequence a little bit in terms
So
of
yes,
starting with a conversion anti-conversion medication first?
yes. So as you have absolutely rightly identified, this patient is in thyroid storm. Why this patient is thyroid storm? Because this patient, first of all, this patient has a biochemical problem which tells us that this patient is in a state of hyperthyroidism. Along with that, what is the definition of the thyroid storm? How do we identify thyroid storm? There is a diagnostic criteria to detect the thyroid storm. Most important, this patient is having a tachycardia. This patient is having a atrial
Mm.
fibrillation with a fast rate. This patient is febrile. That means he is having hyper so high temperature, and the diarrhea. All they are all clinical state uh, stating that this patient is a clinical feature of hyperthyroidism as well. So this patient is both clinical and the biochemical features of hyperthyroidism, which tells us that this is a thyroid storm state. Whenever there is a thyroid
Mm.
storm state, because of this thyroid causes catecholamine surge. So that we need to suppress this catecholamine surge. That is the most important part of the management. First, we need to suppress the
All right.
catecholamine surge. For that, you need to have a beta blocker. Most commonly, if somebody asks what is the choice of the beta blocker in these patients, they are the short-acting beta blocker is the choice. Like suppose this patient is an ICU,
Esmelo.
Espanol should be the choice. It is not the
Mm.
long-acting beta blocker that we commonly use. We should use the IV Espanol as a continuous infusion dose. With that thing, we need to control the sympathetic drive. Along with that, we need to give the propylthyroxine. Now,
All
again,
right.
this sequence matters because they act fast. Beta blocker act fast to control the symptoms. Like suppose these patients sometimes you might get a questions with a clinical feature of hyperthyroidism and that thyroid storm. The patient is in failure where there is a where you will not be able to give beta blockers also if the patient is in an LV failure. Then it becomes a clinical dilemma whether we need to give beta blocker because the patient is already in left ventricular failure. Sometimes there is an option between the beta blocker uh, and amiodarone to control the failure part and control the rate part. So that adjustment you will have to know depending on the clinical scenario. In EDIC, again, what I have emphasized in the previous class as well. In the any kind of examinations, they usually try to understand that how you are equipped with to deal with a complex clinical scenario. So most of the questions are based on the clinical in the practical clinical based scenario, and they will want to see that the how best you can manage a particular scenario. Now, what will happen if you give a propylthyroxine? If you choose the option B, why the option B is not correct over here? Like we can give a propylthyroxine. Yes, of course, you need to give a propylthyroxine in this patient, but not before beta blocker. We need to give beta blocker probably most of the time. Practically, what we do beta blocker at the same point of time we give oral propylthyroxine. Now we know that we start giving IV beta blocker, and we know that it will start acting faster. And at the same point of time, we give a propylthyroxine. So that takes some time to act to to have release of the thyroxine hormone and the conversion of the T3 to the T4. And most important aspect in this question is to give iodine after propylthyroxine. So that is the most important thing. The dilemma is always probably in option B and the option C. But why option C is more correct over here? Because we need to know that the beta blocker is more important to control the symptom. After that, we need to give antithyroxine hormones. Is that okay, doctor?
Thank you so much. I appreciate it.
Yeah, you're welcome. So coming to the these questions, has anybody answered this question? So let me see in the chat box. Dr. Hiren has given. I hope everybody has given, will give a correct answer over here. So by now that everybody must be knowing that it is important to give iodine after antithyroid drugs. Why it is we do not give iodine before antithyroid drug is as correctly everybody has said. It might cause exacerbation of the thyroid hormone release. But again, it's very important as a very important concept in to know that it's very important concept in the management of the patients of the thyroid disorders. What happens if we give iodine first? There is a paradoxical increased hormone synthesis, and we always give thiamide first or propyltyrosine first, and we give iodine after 1 hour. There are a lot of hospitals, a lot of centers in Western countries where we get an IV thyroid. In India, we do not give an IV thyroid, IV iodine. We have only oral iodine. So we give oral iodine after we give the thiamides. Now, two important concepts that we need to discuss over here, I will discuss over here, is one is Wolff-Chaikoff effect and second is the Joad-Basedow effect. What is Wolff-Chaikoff effect? It's a decreased hormone synthesis with iodine excess. So it's a body's protective mechanism. Joad-Basedow is increased hormone synthesis with iodine excess that happens in this kind of scenario when we give IV iodine first, and there's an escape phenomena. Let me just discuss this part and in little bit detail. What is Wolff-Chaikoff effect? So there is an acute inhibition of thyroid hormone synthesis happens after exposure to the large iodine load. So why it is a protective mechanism of the body? So it's a protective mechanism of the body because what happens when somebody is exposed to the excess iodine, the thyroid shuts down the organification of part of the iodine. So that means that it decreases the TPO activity and decreases the synthesis of the T3 and the T4. So this is a thyroid hormone autoregulatory protective mechanism. So it is a physiological thing that happens. It begins within hours of large iodine exposure and the effective transient. It doesn't last long. So it lasts only for 7 to 10 days of iodine exposure. After that, there is an escape phenomena that happens where thyroid hormone resumes the hormone synthesis and bypasses these autoregulatory mechanisms. Now, what is the clinical relevance in the issue? First thing is that we need to give iodine after propyltyrosine or antithyroid medications. So that is one important thing. If we do not, then we exploit the effect of the Wolff-Chaikoff effect. And if we give it before thiamide, there is a paradoxical thyroid hormone release, which is called Joad-Basedow phenomenon. I'll come to that part. It's important to know that the amiodarone and iodine-related contrasts that are important source of iodine in day-to-day practice. Like we remember a patient who apparently didn't have any thyroid disorders. He undergone in one contrast procedure, CT contrast procedure, and after that he developed that patient developed some features of hyperthyroidism. So that tells us that because of this iodine load, the patients developed the features of the hyperthyroidism, and it is also important in the thyroid storm management. What is the Joad-Basedow phenomenon? So Joad-Basedow phenomenon is iodine-induced thyrotoxicosis that happens in the autonomous thyroid tissues. Now, what happens that normally the body, as I've said, normally because of this protective mechanisms of the autoregulatory mechanisms of the body's physiological thyroid, they protect the body from the excess iodine load. Now, when the thyroid glands are not normal, like somebody who has a latent thyroid disorders or latent Graves or latent MND, in that patients, the autoregulatory mechanisms are bypassed. The autoregulatory mechanisms, they do not take part, they cannot work properly. So what happens in that patients in the autonomous tissue, this autoregulation is defective. So excess iodine load increases the thyroid hormone synthesis and release, and it causes the thyrotoxicosis. This is the Joad-Basedow phenomenon. Common issue triggers, as I've discussed, that it's a So like suppose somebody who has undiagnosed or latent graves, they get a CT contrast or iodinated contrast, then the thyrotoxicosis features can be prominent. So this is one clinical entity everybody should know. Or suppose somebody who is taking amiodarone, then they can have this Joule-Besdorf phenomenon and they can develop the features of the hyperthyroidism. Who are at risk? Usually the somebody who is elderly with multinodular goiter or patients with a latent Graves' disease, they can develop the features of the thyrotoxicosis with the exposures of the iodinated contrast or iodine-related medicines. So this is the basic difference between the Wolff-Chaikoff effect and the Joule-Besdorf phenomena. So let's proceed for the next question. A 60-year-old man with an issue with amiodarone develops thyrotoxicosis. Again, amiodarone-related thyroid problems are very much favorite to the intensive care-related examinations. Amiodarone develops thyrotoxicosis. His thyroid ultrasound shows no increased vascularity. Which of the following is the best treatment approach? Again, so there is a 5 different options are there. Amidon-related thyrotoxicosis or amidon-related thyroid disorders. Amidon can cause both features of the thyrotoxicosis and features of hypothyroidism. Now, how do we need to treat this thyrotoxicosis? Anybody has given any answers? So let's see if anybody has given any answers to it over here. Stop thyroid. Okay, stop amidon. Okay, somebody has given answers. Stop thyroid. Stop amidon. Answer C. Okay. Type 1 AIT. Huh? So again, over here, it is important to understand what is amidon-related thyrotoxicosis, what are the various types of it, and it is important again. There are two types of the amidon-related thyrotoxicosis. One is type 1 and a type 2. The treatment of the type 1 and the type 2 are different. It is important to know understand which type of disease we are talking about over here. Here, what are the salient features over here? Here, the patient has features of the thyrotoxicosis, but important feature which has been provided or clues which has been provided in the question is that the thyroid ultrasound shows no increased vascularity. That tells us whether it is AIT1 or AIT2. So a lot of people has given answers. The answers over here is B. So why it is? Because it is a amidon-related thyroiditis, which is type 2. It's a destructive thyroiditis. Here there is no role of anti-thyroid medicines. We need to treat with the steroid. So if the patient had AIT type 1, then the thiazolamides are useful. Now coming to the difference between the AIT1 and the AIT2 or amidon-induced thyrotoxicosis 1 and 2. Now, again, most important points over here. In type 1, what happens? There is an increased thyroid hormone synthesis because of the iodine excess from the amiodarone. It happens especially in somebody who has a pre-existing thyroid disorder. So they are more prone to develop thyrotoxicosis whenever they are exposed to the amiodarone. Whereas the type 2 is a more destructive process when the process of the thyroid gland getting to the release of the preformed hormone. So the synthesis doesn't synthesis is not elevated, but it is what happens is that because of this iodine in the amiodarone, there is a release of the preformed hormone. So that causes the AIT type 2. In AIT type 1, usually the patients have some pre-existing thyroid disease, like the patient might be having nodular goiter or diffuse goiter. Whereas in the type 2 AIT, the thyroid gland are usually normal or the glands are small and they have a limited vascularity. If you see that the vascularity in AIT type 1, the vascularity of the gland increases, whereas in the type 2, the vascularity in the gland remains normal or it decreases. The treatment of the type 1 is to give antithyroxine and medicines like propylthiouracil or methimazole. Propylthiouracil is better than the methimazole because it prevents the conversion of the T4 to the T3 as well. Whereas in type 2, it is the steroid is the treatment of the choice because here the synthesis is not a problem or conversion is not a problem. It is here in the thyroid. It is a we need to it is a destructive thyroiditis, so we need to give a steroid to prevent the release of the preformed hormone. Okay, so should know that this type 1 and a type 2 AIT. Any questions over here or otherwise we'll proceed. Okay, so a 40-year-old woman undergoes a total thyroidectomy, is admitted to the ICU for monitoring. 6 hours later, she develops perioral tingling, carpopedial spasm, prolonged QT on ECG. Which of the following is the best immediate management? So again, it's very, I feel that it's a very easy question. So everybody should be able to give this answer. Oh, the correct answer has also been given. Oh, sorry. So correct answer has also been given. So here we understand. So these patients at the time of total thyroidectomy probably had inadvertent removal of the parathyroid gland as well. So it caused acute hypocalcemia. So acute hypocalcemia we need to treat with IV calcium gluconate. Okay. So the answers here has already been shown. Okay, coming to the next question. A 23-year-old woman admitted to the emergency department from her office for the third time in the space of 2 months after having suffered a syncopal attack. So, young lady came with a syncope. On questioning, she admits to having felt very tired over the last few months, with intermittent abdominal pain, being dizzy on a number of occasions. On examination, she looks slim and tanned. BP is normal at present, but drops to 85 to 65. So on standing, so she has a feature of orthostatic hypotension. Potassium is little raised. FT4 is normal. TSH is normal. But diagnosis fits best. Again, I feel so. This is the mucosal picture. So, what is the diagnosis over here? Anybody? Yes, adrenal insufficiency. Somebody has already given answer. So again, this is more diagnosis related questions. In EDIC, you will rarely encounter questions on diagnosis. Most of the questions remain on the management of the patients. So usually the questions remain on the management. This is not a typical EDIC type questions, but again, the answers over here is the primary adrenal failure, as rightly said by most of the people. So we have correctly identified the entity. So answers over here is B. From this point, we'll go to the management part. Okay, a 48-year-old man collapses with a severe headache, visual loss, hypotension, MRI shows pituitary hemorrhage. Okay, this patient has presented with a pituitary hemorrhage. What is the most critical first intervention in the ICU? Okay, so somebody has come with a pituitary hemorrhage. So what is the problem that we have encountered over here? Over here also the answers have been given. So the patient has a pituitary hemorrhage, so this patient is having a pituitary apoplexy. So pituitary apoplexy, there is a secondary adrenal insufficiency, which is immediately life-threatening. Steroid. So that is the most important intervention. So answer B is the right answer over here. Both the questions, the answer has already been given. Okay. I don't know why my animations are not working. Coming to the next question. 49-year-old women presents with a complaint of polydipsia, fatigue, weight loss. She was successfully treated with prolactinumab 3 years ago. It is suspected that she might be having MEN1. Which of the following underlying conditions she is most likely to have? Again, this patient comes with a polydipsia. You suspect MEN1, so it has already been given. So the question very specifically asks that what of all these things are associated with MEN type 1. So again, multiple endocrine neoplasia, two types, MEN1, MEN2, I feel all of you know. Men type 1 and type 2 are very, very favorite to all EDIC exams. So usually in all EDIC exams, in MCQ based exams, we expect at least one question on this main 1 and main 2, either main 1 and main 2. So you should know that regarding this part, main 1, main 2, so they are very, very favorite topic. Coming to the answers. So anybody has given answers? Answers, I think B is the answers that have been given. So answers over here is the B, right? So now coming to the main 1 and the main 2. Again, I am not going into details of the main 1 and main 2. Main 1, as all of you know, it's a 3 P's: parathyroid, pituitary, and the pancreas. We get the parathyroid adenoma. We get the pituitary problem. These patients usually have a kind of history of brain surgery because of this prolactinoma, and they come with the features of acromegaly or Cushing's disease, and they have a pancreas related problem like gastrinoma or insulinoma. Like these patients, sometimes they come with a multiple ulcers in the abdomen, or peptic ulcer disease like this. And main 2 is 2A and 2B. 2A is the parathyroid pheochromocytoma. Usually main 2A is the pheochromocytoma along with the medullary carcinoma of thyroid. 2A and 2B is differentiated with the presence of the parathyroid hormone abnormality. It's 2A, and Marfanoid habitus is the 2B. So that is how it has been distinguished. Coming to some questions of the diabetes. A 17-year-old girl presents to the emergency department with blood glucose of 29 millimole per liter. She is known to have type 1 diabetes, pH is 7.12, with a serum bicarbonate of 11. Urine analysis shows plus 4 ketone. Which of the following statement about the diabetic ketoacidosis is true in adolescent and adult? Myocardial infarction is the precipitating factor. Infection is the precipitating factor. Bicarbonate level can be normal in decay. Blood glucose level can be normal in decay. Non-compliance with insulin causes 5% cause of decay. Okay. Again, I don't think it is a very difficult question. So if you can see that the myocardial infarction, they are the precipitating cause. Again, it might be a little tricky over here for people, but if you keep the basic corrects over here, so the idea of these questions, again, nobody knows whether this percentage is right or not. To be very frank, I do not know whether it is MI is a precipitating factor in decay, but I do not know whether this percentage is right or not. Infection is a precipitating factor of decay, but again, I'm not very much sure about this percentage. Bicarbonate level can never be normal in decay, so usually bicarbonate levels are always here. Dr. Abhishek, no, it's not K type. The answer somebody is D. So in decay, it's important to know that in decay the blood sugar level, blood glucose level can be normal. So sometimes the clinical entity called euglycemic decay or euglycemic ketoacidosis. In that case, in those patients, the blood glucose level can be normal. So rest of the options are the false. The D is the correct answer over here. Now coming to some other questions of the decay. Decay again is one of the very favorite topic of it's in the examination, especially the management of the decay. So the next question is 22-year-old male with a new onset diabetes presents with a decay. During the treatment, his glucose level falls from the 480 to 220 in the first 4 hours, but pH remains 7.22 with a bicarbonate level 10 and an gap of 22. Which one is the most appropriate next step? So these patients blood glucose level fell down, but pH level, bicarbonate level, they didn't improve. So now what is the most important step? This is more EDIC type question. So they need to know that whether you can identify the problem over here. So what will be the correct answer over here? A, B, C, D, E. Stop insulin infusion, continue insulin infusion, add 10% dextrose, start IV bicarbonate, double the rate of insulin infusion, reduce fluid replacement to avoid some edema. Okay, so again, everybody should be able to answer this question because this is a very common clinical dilemma that comes in the day-to-day clinical practice. What is the problem over here? This patient's glucose level have fell down, but the pH level remain abnormal. So what is the correct? I want everybody, all of you, to give a correct answer to this question, because this is a very basic questions of the management of the diabetic ketoacidosis. What happened over here? Let's see if somebody has given answers. Okay. B, E, B, yes. So anybody who has given answers, B is the correct answer over here, because we need to know that how we understand that whether the basic pathophysiology of decay or diabetic ketoacidosis is getting is coming into the resolution phase. Now, how do I understand that the decay is being resolved? Is that we check the bicarbonate level and we check the NN gap. It is not the normalization of the blood sugar that tells us that the decay is being resolved, or the decay problem is getting resolved. So here it is very important so decay is a state of insulin, absolute or relative insulin deficiency. So it is very important to continue insulin infusion over here. But again, the sugar level has precipitously fall from the 480 to 220. So it is important to maintain the sugar level as well, and at the same point of time we need to continue the insulin infusion, because unless you continue the insulin infusion, the ketoacidosis, that is the basic pathophysiology of the diabetic ketoacidosis, the ketones will not get metabolized will not get metabolized. So the basic pathophysiology will not get corrected unless we give the correct dose of or adequate dose of insulin. So here the major problem is in decay the ketones acts as an acid. So we need to convert ketones to normal glucose. So that we need to metabolize that, and insulin facilitates the metabolism of the ketone. So we need to give adequate insulin over here. And how do we understand whether insulin levels are adequate or not? We see the bicarbonate level and the NN gap. If the NN gap is getting corrected, that means okay, our insulin dose are proper. So to give the proper insulin dose, if we need to give additional dextrose, that is also accepted. So that is the basic mechanism in the management of the diabetic ketoacidosis. So another questions on the same topic. A 50-year-old male admitted to diabetic ketoacidosis, which has been triggered by severe gastroenteritis and profuse vomiting. His initial labs are pH 7.35, PCO2 of 45, bicarb of 24, sodium level is 138, chloride level is 88, and serum ketones are very strongly positive. What is the most likely acid-base disorder present over here? Again, this is a very classical EDIC type question. So we need to very critically analyze these questions and give the answers. The 4 options are given over here. I don't know why there is not 5 option. 4 options are over here. So we need to know we need to tell them what is the correct option. High NN gap metabolic acidosis with respiratory acidosis. High NN gap metabolic acidosis with metabolic alkalosis. Okay. Normal NN gap metabolic acidosis with respiratory alkalosis. Metabolic alkalosis with respiratory alkalosis. Okay. Okay. So anybody? So let me see if somebody has given answers. 5 minutes left. Okay. Okay, we'll just complete this decay part and then we'll stop. The answers over here, everybody has given B. So what is the problem over here? So is this, so first of all, is this acid ABG that has been provided, it's normal. So whether this patient is actually in decay or not. This patient's pH is normal, bicarb is normal. So is this patient is in a decay? So that is the first question that we need to answer, whether this patient is in actually in diabetic ketoacidosis or not. So what do you say? So this patient is having a this what acid-base disorder this patient is having? Here again, this here the pH is normal, bicarb is normal. But if we calculate the anion gap over here, what will be the anion gap over here? The sodium of 138 plus chloride plus minus chloride minus bicarbonate. So it will be elevated. It's more than 20 if I'm not wrong. So it's a high anion gap metabolic acidosis there, but the patient's acid base is normal. So it is a mixed acid base status. So it's a mixed acid base status. That means so there is a coexisting metabolic alkalosis there. Now, why this patient has developed metabolic alkalosis? What is the clinical clue over here? This patient had developed decay due to gastroenteritis and the vomiting. So it's the vomiting which had caused the alkalosis, metabolic alkalosis. It's a concomitant metabolic alkalosis because of the hydrogen ion loss because due to the vomiting. So here again we need to know that we can't afford to miss the diagnosis of decay in with this kind of APG. So this patient had high anion gap metabolic acidosis, but at the same point of time, anion gap is elevated. So what we do, we calculate the delta ratio, like delta anion gap and the delta bicarb ratio, and we try and find out whether the patient has a concomitant alkalosis or not. So this is a mixed acid base abnormality. A 17-year-old girl with diabetic ketoacidosis develops sudden headache, bradycardia, and decreased consciousness after 8 hours of therapy, which is the most likely mechanism why this patient has developed. So what is the problem over here? A, B, C, D. Again, this is everybody should be able to answer this question. What happened over here? Yes, 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 yes. I think all of you are doing great. 1 minute. Hello. So answers as has been given rightly the answer is A. So it causes cerebral edema. So if we rapidly correct the sugar level in patients with a decay, that causes cerebral edema. Cerebral edema is more prominent in patients who are young, and if somebody who is very young kid developing decay or pediatric group, so they are more at risk of developing cerebral edema because of the osmotic fluid shift. Osmotic fluid shifts causes the rapid osmotic correction. Okay, so somebody has raised the hand. Yeah, please unmute and ask Dr. Jaideep.
Hello, sir.
Yes, tell me. Yes, Dr. Jaideep, I can hear you. Okay. So we'll do the last questions over here because we do not have much time left today. During decay management, which of the following best defines the resolution of the ketoacidosis? Blood glucose level, pH level, serum ketone level, ABCD. So this is the last question today we'll do. After that we'll wrap up. Chat box. Let's see that whoever has given answers. Lady, Dr. Abhishek. See. Good. I think that everybody is giving the correct answers over here. So correct answer is C. As I have told previously, it is not the blood sugar level that tells you the resolution of the ketoacidosis. It is the correction of the serum ketones. It's not even the urinary ketones. Urinary ketones stays positive even for long, even after correction of the ketoacidosis part. There's a serum ketone becoming normal, bicarb level coming back to the normal, and the anion gap getting corrected. So this biochemical criteria tells us whether the decay is getting resolution or not. With that thing today.
Hello, sir.
Hello.
Hello, sir.
Yes.
Sorry, sir. I raised the hand previously, but I couldn't speak.
No
Sir,
problem.
in previous question,
Hmm.
sir, previous to previous question means previous.
This one,
No, sir. Again, previous.
again previous. This
Yes,
one?
sir.
Yes, yes.
Yes, sir. Yes, sir. In this question, should we not decrease the fluid replacement also, sir, to avoid the cerebral edema, sir? Because we are rapidly correcting the sugars.
Yes. So now, so the thing is that Malab, you need to understand what is the essence of the question over here. Here the essence of the question over here, this patient's glucose level fell down rapidly,
Yes, sir.
but the acidosis has not got corrected. So that means your ketoacidosis has not got corrected. So essence of the question, what examiner wants to ask is that whether it is whether the rate of insulin infusion, whether you need to decrease or not. Now, had it been a kind of questions on HHS probably, where the fluid management plays a more prominent role. The decay, the insulin administration of the insulin plays a more prominent role in the resolution of the ketoacidosis. Whereas I'll come subsequently in the differentiation between the decay and the management of the decay and the HHS. HHS is the major. We need to give fluid. We need to administer fluid to correct the hyperosmolar state. In decay, we need to give
Yes, sir.
insulin to correct the ketoacidosis because the ketoacidosis is the most prominent. Here, the correction of the ketoacidosis has not happened because the insulin administration probably has not become adequate. So here, the essentially what we need to give, we need to continue administering insulin. Maybe if required, we need to increase the rate of insulin infusion. But at the same point of time, we need to maintain the blood sugar level as well. To maintain the blood sugar level, we need to administer supplemental dextrose. So that is the most, and whenever in management of the decay, whenever the blood sugar level comes below 250, so we start supplementing the dextrose IV. So either in the form of 5% dextrose or in the form of 10% dextrose. So that is the essence of the questions over here. So correction of the ketoacidosis, for correction of the ketoacidosis, you need to require insulin. Now, again in the questions, there is no mention of how much fluid has already been given so far. So the last option, that is why it will not be correct, because in the question itself, there is no mention in the administration of the fluid. Fluid administration always plays a part in the management of the decay because of the hyperosmolar state, but it comes along with the management of the insulin. Is that okay?
Okay, sir. Thank you, sir.
Yeah. Okay. Thank you. I think with these things, Padma is telling us to stop. So with these things, we'll close today. If required, we can take a kind of another class tomorrow or day after tomorrow, and then we can complete the session. Is that okay? Padma, is that okay?
Yes, sir. Yes, sir. It's okay. We'll be scheduling a class 2 soon.
Yes, yes. So we will
Thank
let
you,
you know. Thank you. And again, when is your exam, by the way, EDIC Part 1 exam? When is
So
your exam?
it's from 23rd September.
23rd September. Okay. All the best to all the aspirants who are appearing for the exams in EDIC Part 1. Thank you. With
Thanks.
that, let's close this session.